I'd like to acknowledge that we're on the unceded traditional territory of the Musqueam, Tsleil-Waututh, and Squamish nations. My name is Tracy St. Clair. I live currently in Penticton on the traditional territory of the Silk people and of the Okanagan Nation. Thanks very much for joining us. We have 3 presentations over the next hour, and looking forward to it. So, without further ado, I'll call up our first presenters, Joanas, Wong, and supported with Tamsin, Morgana. And they're a duo. You'll see them again in the 3rd session, but opposite.
Hey for everyone, my name's Jonas, like the Jonas Brothers. I am the project manager for the Richmond Virtual Health team, and today I'm going to share with you our webcam project with our Richmond NICU. In VCH, we acknowledge that we live, work, and play on the traditional territories of Musqueam, Squamish, and Tsleil-Waututh peoples. And for the presentation today, we have nothing to disclose. So our virtual health team has been working with the Richmond Hospital Neonatal ICU for this project. We work with the clinical nurse educator and manager and the director for a project. We are on a 6-bed unit in an open floor space where we have 2 registered nurses for both days and night shifts. Let me break everything here. Thank you. So how this opportunity came about. So when the virtual health team was doing a current state assessment with the various programs in Richmond Health Services, the clinical nurse educator at NICU actually brought forth this idea to explore improving family-centered care at the NICU by utilizing webcams to hopefully allow patients, our babies' families, to be able to see the babies from home when they're not able to be at the hospital. So we took this idea forward and did some literature research and environmental scan. And we concluded that the reviews are quite positive and help reinforce this idea. Majority of the parents and professionals believe that NICU webcams are an important advancement for the provision of neonatal care. We also found that webcams are actually being utilized across Canada and worldwide. In Canada, it's currently being used in NICUs in Alberta, Saskatchewan, and Ontario. So we kind of pulled all the information together and summarized into like a pros and cons format for both in the perspectives for families and clinicians, and brought that to the stakeholders. So for families, it's yielded higher satisfaction and confidence care. It's improved bonding experience both in perspectives of family members who have other obligations, whether it be they have other children to attend to, they have obligations to return to work while babies are still in NICU, as well as family members that are rural or international families where coming to be here physically with the babies are quite difficult. It's also lowered stress and anxiety level. One concern that was brought forward was technical difficulties, and we've chosen a vendor that offers 24/7 technical support. For clinicians, this is an opportunity to support family-centered care. The cameras are very easy to install and use, and there's no major training that would be required to support our clinicians. One thing that's been brought forward is the privacy concerns. So whether it be around other babies and families within the unit, which is especially applicable for us because it's an open floor space, or for our clinicians. So with this, we kind of mitigated with lots of conversations and the camera we chose. So the picture of the camera, you can see that, first of all, the camera window is very small. It's meant to work only for within 2 meters of like the bed space. That's kind of where it would focus on. This window is very small where it's only meant to capture the baby's head and maybe part of their torso. Clinicians that are working with the babies, you would only really see their hands. That said, there is a privacy mode that can be activated by staff at the bedside very easily. There are no audio options, so there's no way it would pick up any sort of conversations or audio from the bedside, as well as the camera angles are adjusted by staff and it is live streamed only, so that it doesn't keep recording of any of the babies. Lots of people work in the background to help bring this project to life. Biomed's been responsible to help us with equipment inspection and also coming together to figure out how the cameras would actually be mounted rather than it sitting on random IV poles and being pushed around the unit. Security's done a risk and threat assessment. IMITS has helped us to configure all the networks. So not only are they responsible for identifying how the cameras would get connected to the network, but making sure that it's on its own network path. So it wouldn't share any of the network path with our critical infrastructure. Legal's been involved with all the service agreement and contract agreement, insurance review, as well as parental consent, and privacy's done a deep dive into utilization and flow of personal information. So the left upper corner is a mock-up of how the cameras will be mounted in our NICU. So we have 6 bed space, 6 cameras, so each bed gets one, and they work regardless whether the baby will be in bassinet or incubator. So every bed space will get one and mounted the same way, except for our resus space. Our resus space just won't have a bed or a camera. Privacy mode is easily turned on by clinicians, and we've left it completely up to our clinicians when they think it is appropriate. And all it means is tap on the screen, and then the blue screen would turn on with the privacy screen enabled at the bedside. From a viewer's end, all they're going to see is an offline image, and it's customizable. And our teams landed on, it'll say, your little one's busy, please check back later. So how this will actually work on the unit. So baby gets admitted to NICU, baby gets settled in, and when there's an opportunity, our nurses will offer the opportunity to the parents or legal guardians in which they may or may not consent. Currently, the consent form is in English only. They will sign the consent, but we do have the virtual interpreter to overcome any language barrier. Parents would be given information for them, which includes information on how to access the portal, contact for tech support, as well as help set some expectations of what they may or may not see on the camera. The parent information guide is translated to multiple language to help support our parents. Once they've consented, our nurses will sign into the portal and provide a username and password. The username and password is computer generated. It's a unique combination that will only be utilized for one baby ever. So once the baby gets discharged, it gets permanently disabled. It'll never get reused again. One interesting thing is this entire process, no personal information is ever used from the parents or the baby. And then at the parents and legal guardians' discretion, they can decide who they want to share that access with. And then finally, they will access the portal. So the portal can be accessed in multiple ways, whether it be through app on a cell phone or a web browser. Maybe this will advance. Maybe it won't. Oh, there we go. So this is kind of all the buckets of work we've done so far. We certainly had wish that we were already live when I come to present, but we had some shipping delays and also staff shortage and biomed. So our go live date is actually on 21st of June. We're just finishing up on staff training, and we'll be ready to go in a couple of weeks. In terms of how we've done the project, there are a couple of things I kind of want to highlight. Even though we know the webcams have been used in other places in the world and very much supported, this is definitely a foreign concept for our staff. So ongoing stakeholder engagement and communication has been a huge piece in terms of change management, whether it be early engagement with staff explaining the concept, holding meetings, Q&As with both physicians and nursing to answer all their concerns, and including them in terms of what information they want to be included in the parent guide. And even now, through conversations, facilitating a lot of concerns in training has been really important. The other piece I want to share is the pre-implementation survey. So we've done survey with both staff and parents who have babies in the NICU now, just kind of introducing the idea. So one story I want to share is our clinical nurse educator went to one of the moms who has a baby in the NICU right now just to introduce the concept and just kind of get a sense of how would you feel had this been an opportunity. And it was really sweet because the mom got really teary just talking about how, I was just in conversation with my sister who isn't able to be here to see the baby, and how great would it have been that there was an opportunity for you to see the baby. So overall, everyone's really excited for this to go live. We'll go live in a couple of weeks. We'll do evaluation, and if this goes well, the overall vision is that we want to expand this to our second NICU in Lionsgate.
Sure. just because I don't know, I'm wondering, are families allowed to, when you mentioned about the sister-in-law or whatever, the aunt maybe being able to see the baby, and I was thinking about the COVID restrictions, are families allowed to like take pictures or like take video of their babies and share that out of the NICU, or that's not generally allowed?
So right now, I think they are able to, just then it would be dependent on whoever's at the bedside to be able to facilitate that. And I think the benefit to this is even if the parents are not at the bedside, and so they have to go home for whatever reason or to rest, they would still have the opportunity to see their babies. And it takes the onus away from the parents or whoever's at the bedside to send that information. Yeah. Yes?
I'm Sandesh. I'm a neonatologist from BC Women's Hospital. So thank you and taking on this Herculean, very important project. So the thing which I liked really about is that the systematic way how you have provided a framework of bringing any technology to the patient bedside. In that way, this is really, really very helpful. And so many of us really think that a lot of technologies are available which may benefit patient experience or quality of care. But we are just afraid because how do you involve all these 10 or 15 different departments, bringing them together? This provides a good pathway, and you have really come close to piloting it. I really applaud you on this excellent work.
Thank you. Happy to share.
Yeah. I have a question. Yes, certainly in an open bay area when families, if they are sick themselves, they cannot visit, it would be helpful. But in terms of evaluation and sustainment, have you think about the balancing factors? Just because this option is available, would families decrease their visits to NICU and physically hold and then engage in baby's time and care? So any comment would be helpful.
Oh, that's interesting, actually. So just off the top of my head, I don't know that in the literature that that's ever been brought up or assessed. And I don't, the only thing I can kind of add to that is in our environment test scan, speaking to our Canadian partners, that's also never been brought up. So I assume that wouldn't be a concern, but worth working into our evaluation plan for sure. Yeah.
How are you thinking of measuring the impact for patients, well, for families' experience of care once you're live and in field?
Yeah, so our surveys we're targeting the best clinicians first of all, just to make sure that like their workflow and how they're impacted. In terms of families, we are going to do surveys when babies are discharged, so we'll capture all the legal guardians and parents that way, just to understand their experience, whether it was positive or negative. The surveys can also be worked into the portal. So we are also hoping to gather survey input from other family members outside of the immediate parents or legal guardian that we would interact with within the NICU. So we're hoping to collect data that way. Yeah.
Yeah. If you need help designing the questionnaire or anything like that, setting up the tool, we have a patient experience team at BCH who would be happy to help.
Yes, I know about you guys.
Little plug there.
Perfect.
Thank you.
We just need the mic to catch it for the live stream. Yeah.
Just a question around access for all parents. If they don't have the required technology to receive the live feed, is there any opportunities to support that for those families that might not have that access?
Yeah, at this time, we don't. I know our previous clinical planner had talked about exploring whether there would be ways to collect and lend out equipment. We haven't quite gone down that path. We're definitely hoping by the portal is easily accessible by multiple platforms. So we're hoping that will help increase the accessibility a bit. But if they do not have access to technology like devices or internet, unfortunately, those members would not be able to access the portal right now.
Any further questions from anybody at all? Okay, seeing none. Well, thanks again for the presentation. Maybe another round of applause.
So next we've got Julie Lockington and Tina Cheng, and talking about QR codes.
How does the clicker, just this way?
Yeah,
Okay.
forward and back.
Okay. Hi. We're really thrilled to be able to speak to you about a QI intervention that we implemented at Vancouver General Hospital Emergency Department to look at how we could improve the provision of discharge instructions using a technology-based solution. I'm Julie Lockington. I, at that point in time, was the emergency nurse clinician, but I am always at heart an emerge nurse, a very long time emerge nurse, since I'm quite old. And once an emerge nurse, always an emerge nurse. And this is my colleague.
Hi everyone, I'm Tina. I am a recent MPH graduate from UBC.
Like last Wednesday, just graduated.
So thank you. Yes, and then during the time of the project, I was a summer intern with the council. It's a wonderful opportunity. A little plug here, but
Yes, exactly. So we were thrilled to be able to hire Tina through BC Patient Safety Quality Council through their summer internship project, which gave us a little bit of funding and some hours. And then I'm also just another proud, I'm like a proud mama. She just really spearheaded our project and led it and ran with it. And I basically just sort of supported from the background and provided that clinical lens. But this project is really a testament to Tina's time and efforts. We have nothing to disclose. I have occasional profanity. I'm sorry. I'll try to keep it under control, especially because this is live and recorded. We respectfully acknowledge that we live, play, and work on the land of the Musqueam, Tsleil-Waututh, and Squamish peoples.
so the projects that we're talking about today really had two aims. So through the use of technology, we want to reduce barriers for staff to improve efficiency and consistency of provision of discharge resources for patients being sent home from BCH ED. And from the patient side, we really want to improve accessibility and reliability of discharge resources.
One more time. Perfect. I have to excuse my old school use of paper notes here. All right. So we knew anecdotally in our emergency department, and that's, part of it is just from personal experience of being the clinician trying to provide discharge teaching and discharge resources. Some is from what we hear from colleagues, and then also from patient reports, i.e. complaints. We know that discharge teaching can be an issue. And so we spent a bit of time, though, trying to investigate the problem a little bit further. When we got this funding, we tried to take an organized approach to deciding what kind of a tech-based solution we could look at. So we didn't make any assumptions. We did a needs assessment of the department, an environmental scan, not only of our department, but also trying to see what other departments across BC were using, what other similarly sized facilities we're using, maybe in Alberta or similar facilities across Canada, Toronto, and then even taking to social media to look at what other facilities could be using in Europe or in the States, somewhere else. And there's quite a variety of technology-based things being done. We also wanted to look at what do staff currently encounter as their biggest barriers? What things do they think are going well, and where do they see opportunities, rather than making assumptions? Additionally, Tina took a good dive into the literature to see what the literature said about what goes into a good discharge teaching, what barriers we know exist, what things patients encounter as challenges. And then additionally, we looked at what was available. We had to look at what was accessible and reasonable given our time frame and our lack of resources, i.e. no money. to be able to implement a solution as well. So we couldn't, create an app, or we have no one who can like program things for us. But what technology might we be able to leverage in spite of those limitations? So we selected our intervention, which is to use QR codes, and Tina will talk a little bit more about that in a moment, and we'll also go more into the data. As to sort of what we found on our pre-intervention survey, and then our post-intervention surveys and chart audits that we did after we implemented the intervention. To read you in a little bit more, in case you've not had the pleasure of a visit to VGH Emergency Department, we act as both a provincial referral center for all kinds of specialty and high acuity type presentations for patients. We also act as a community hospital to our surrounding population. And these two things combined together make us quite busy and quite acute. We have lots of complex patients as well. We see approximately 90,000 emergency department visits, give or take, on a yearly basis. And within the department, there could easily be well over 100 patients in a fairly small physical footprint at the same time together. And of these 90,000 visits that we see, we discharge approximately 80% of them from the emergency department. And you would think that this would make us discharge specialists. But I'll get to that in a moment. So to go back to what we know about what makes a good discharge, we know that when it's done well, that it results in like decreased rate of return visits to the emergency department. Not that we mind you coming back, but we like you a lot, but we prefer you didn't. We know that it's associated with better safety, decreased complications, increased quality, better follow-up, and then also increased patient satisfaction. We know that barriers exist for staff, include time pressures. I want to use that spot that you're sitting in for the next patient who's sitting in the waiting room, waiting and anxious and in pain. And so we're really pressured to sort of move things along. We know that we don't always do well at training how to do this, so it lacks consistency. Patients are often not having their greatest day. They're stressed out, they're in pain, which doesn't make you receptive to like remembering complicated information. We use terminology that people don't understand always. Our resources are not always written at an appropriate education level or in the correct language. Patients, I think, often also encounter us we provide instructions from a variety of different sources. The key one for us, most often used previous to this, was a filing cabinet with just pre-printed papers in it. But if someone had come, let's say, from Alberta Health prior to their training at VGH, they might be going online and getting resources from a place that they're familiar with. And so it created quite a variety in terms of what was being used, which puts us at risk for maybe problems with good quality. Are those resources being updated regularly? Are they updated with a patient partner involved in providing that feedback?
So our project essentially followed the knowledge translation framework adapted from the Canadian Institute of Health Research, with knowledge generation in the middle, surrounded by implementation. So from previous literature review, we know that different types of intervention that looked at discharge, whether it's included a verbal cue or a visual cue, components of technology in that intervention often provided the best patient outcome and also patient satisfaction. And adapting that knowledge to our current situation. Can I see a show of hand if you use a QR code to get in the quality forum today, or have used a QR code in the past 2 days? So QR codes, they're everywhere. It's low barrier, it's easily accessible. It's well known because of the pandemic, and like Julie mentioned, the preprint system has its own barriers, misplacing documents, not the same dates, difficult finding resources. So when we're looking around and find innovative solutions, we realized that, hey, in BC Emergency Medicine Network, they had great discharge resources. They are high quality, they're accessible, and they are also available up to 9 different languages. And the resources by BCEMN is actually in line with future electronic medical records, so the Cerner system as well. So knowing that, our intervention essentially is, as you've seen in the previous slide about those posters with QR codes in them, those are QR codes linking directly to resources by BCEMN. And to start, we picked 3 high-yield areas, so abdominal pain, back pain, and laceration, because these were the top reasons patients come to the ED and they're also discharged home. So how it works is that when discharging, a provider will actually guide the patients or lead them to a poster and help them out while they're navigating, they're scanning that resource, or providers also have the option to send the resource to the patient through EMN using a anonymous link. So before and after the intervention, we did chart audits for about a week, and to see if there's clear indication of giving discharge instructions from the nurse's side and also the physician side. So after the intervention, we see a 12% increase of indication giving out discharge resources to a patient in nurses and a 5% increase in physicians. Looking at the pre-post survey data, so for the post survey, we actually got a lot more physicians involved, and that could be because of the advertising effort that our team has been doing, and also literally the posters were everywhere at VGH ED. It's hard to miss them. And we also had one input from a social worker in that post survey. Some of the highlights from quantitative results. So for abdominal pain, we see a 32% less and 43% less providers thinking that access of resources is difficult or extremely difficult. For back pain, we see a 9% increase in selecting always when we asked how often do you provide patient resources to discharge home. And laceration and puncture, we see a 23% decrease in selecting sometime when we asked how often providers provide discharge resources. Some qualitative highlights. Some providers loved it. They found it so easy to use, it's so accessible, but many also find that it's challenging to guide patients through the process. You have to lead them to the poster, show them, ask them to take out their phone and go through the whole process. And other concerns include what if we're dealing with patients who are less tech savvy? They're not comfortable of using QR codes, and we might really risk not serving that population if we focus on that new technology approach. So overall, we see some good indication of this QR code intervention, but this should and would not replace a paper-based discharge system. What it actually do is that it provides another option for providers and for patients. It's a really simple intervention, really. It's just QR codes on posters, but we see good results. And I think what it adds really is to give that option to patients and see where their comfort level at, and we can better serve them. Our next steps right now is really expanding this QR code-based approach to other priority areas and really collaborating in data sharing with partners like BCEMN to further increase reach and improve patient care.
Time for questions.
Thanks. This is a really, can you hear me?
Yes.
Exciting project. Just so I understand clearly around QR codes, would the patients just get a generic QR code, and then once they had accessed that, they would go down the algorithm to get to the proper set of information?
At the moment, the posters had those 3 top discharge sort of reasons. Patients are seen in the department and discharged home. That was the abdo pain, back pain, and laceration puncture. And that was primarily just for our implementation phase so that we could do some pre and post data collection and be able to compare from before and after. The thought afterwards now is to sort of like look at what is most common. So we could maybe do like a top 10 and then have QR codes sort of labeled for each of those things, you know, crutch walking, you know, wound care, whatever that might be, and that they could scan the appropriate one, and then also one generic code which would lead them to the front-facing discharge instruction page. And then from there, they could maybe like look up something if it was not covered by those initial 10. And that might be part of our future steps as we look at sort of what those most common 10 might be for our department. And it might be quite different for another department. For example, like we don't see any children, we hope, at VGH. Even though children are lovely, we don't see them. And so, other departments might want, sort of pediatric dehydration or like other more commonly used things that they might see, which is kind of nice because it could be very transferable and adaptable for other departments. And cheap, lamination, that's it.
So I wonder if you can comment on what you meant when you said there was alignment with future state CST CERN. I wasn't sure kind of what you're referring to there.
Yeah, absolutely. So for those of you who are not part of Vancouver Coastal, we're still going through, at VGH, we're still going through transition to an online EMR and from our good old paper system. And within Cerner, in its future state, there is links and connections through Cerner to the BC Emergency Medicine Network that are already built in currently. We haven't gone live yet, though. Fall 2022, it's coming.
Go ahead. Thanks for your presentation. I was curious, one of the things that you talked about at the very beginning was that whole notion of folks boomeranging back into the emergency department because perhaps they weren't informed enough about their puncture wound or whatever. Did you actually do any review of return?
No.
And the impact of this intervention on that?
No, we didn't. That wasn't one of the metrics that we were looking at, although that would have been a great idea to look at bounce backs. It's hard to, I think there are many potentially confounding factors with return visits. And while I think it could be a valuable metric to look at, given the narrow population that we were focusing on for our pre and post data, I'm not sure if it would have been easy to necessarily like directly extrapolate to say like this is from the QR codes, because we know that we get return visits for a very wide variety of reasons. Right. Yeah, but it's a great idea, and it is one of the benchmark metrics that we look at as a department as a quality metric. Yeah.
And it's relatable to experience, right?
Absolutely, agreed.
Great, thanks.
I was just wondering about, you mentioned early in the presentation that providers were giving out different resources, like if they had come from Alberta, maybe they have a website that's similar. Do you feel like even utilizing this particular like website, did you think that standardized the staff at all and the physicians in the discharge resources that they were providing, even if they might have been printing them out?
That was the hope, was that we could be a bit more standardized. We are a very large group of clinicians, upwards of 200 nursing staff alone, and 90 to 100 physicians once you include locums at our site alone. And other clinicians discharge as well, sometimes like a physiotherapist or a geriatric specialty nurse could be discharging. And so that was one of the hopes, was that I do believe that clinicians can assess and say whether something is of good quality. I wouldn't want to ever take that decision-making away from clinicians, but on the flip side, by standardizing, we can have a little bit more control over some of those other factors, like patient contribution to the resource development, making sure that it's been updated regularly, those sorts of things.
Adding on to what Julie has said, so just looking at that survey responses, we do still see a lot of variation in people's preference, even in that post-intervention survey about their preferences of different resources. But what might happen in the future is that we gather all the good criteria of the resources that physicians do use, and whether we can improve that and to see if it applies with the EMN resources. I know that EMN right now they're having ongoing discussions and see if they could add the feature of physicians tailoring that resource when scanning through QR codes and deliver that to the patients. And if in the future that discharge resource is so great that everyone eventually would start to use the same resource.
Yeah, if we can make it as barrier-free of a process as possible. We love speed and we love easy in the emerge. And so if we can, I think, steer people towards standardization by removing some of those barriers.
Any additional questions? Probably have time for one more. Yes.
Just wondering, in terms of standardization, through BC Emergency Network or similar networks in Alberta, Ontario, or other places, is there standard patient discharge material available So which would be helpful because there is so much of effort goes in creating one pamphlet. If there are hundreds of questions and all centers doing it again and again, there is a lot of redundancy there, I guess.
Agreed, it is not efficient. So every health authority has their own standardized resources, which may or may not be updated regularly. They may or may not be in more than English and maybe one other language option. And that's even just within the province of BC. I agree, it's quite frustrating. It would be really nice if there was even just like a Canadian-wide type of resource. You know, chest pain is chest pain. It doesn't matter what province you're in.
Okay, maybe a final round of applause for our presenters.
So last but not least, we have Tamsin Morgana, and you are presenting on utilization of virtual queue management and appointment reminders. Thank you.
Hi, everyone. Thanks for inviting us today to present on our waiting room and appointment reminder initiative. For today's presentation, I'm going to speak to our experience through the lens of lessons learned. I'll give an overview of issues, opportunities, and settings, project management, how the Wait While solution works, use cases, and benefits and feedback. Firstly, I just wanted to acknowledge that we're gathered today on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And nothing to disclose. So our first lesson learned was that the COVID pandemic response measures provided an opportunity to address some known issues within our health authority. And it began with the ministry mandate for people to social distance. This meant that we needed a solution, and we needed one quickly to help manage the number of people in waiting rooms. And our virtual health team joined a provincial group that formed quickly to shortlist, evaluate, and select a vendor. And through the process, Wait While, with expertise in texting and waiting room management in the retail sector, was chosen, and our team went to work on the implementation plan to apply it to healthcare. And I just wanted to give a shout out to the Lower Mainland Medical Imaging, some leadership from that team who really got this going in the first place. With the introduction of Wait While for waiting room management, staff at various clinics and programs around VCH were also asking if it could be expanded to assist with other known issues due to outdated administrative systems. And the core known issue was a lack of a solution that could automate appointment reminders and provide clinic information rather than time and cost-intensive manual phone calls by administrative staff or no reminders at all. And without a system for appointment reminders, staff reported numerous issues that result in delays in patient care and clients, for patients and clients, and their own frustrations. And you can see on the board here that there are a number of them listed, such as missed appointments and workflow inefficiencies. And we soon learned that Wait While could be expanded and used to tackle some of these issues as well. Am I going the right way? Yeah. So our second lesson learned was that the texting solution can be used in any care setting in creative ways. Our team and staff have identified more than 15 ways that Wait While can be used to automate and transform some work processes to free up staff time to improve quality of care. Waiting room management, appointment scheduling, reminders for appointments, reminders to complete your forms, reminders for prep, patient pickups. These are just a few ideas, and I'll highlight some use cases as well, and you'll learn other ways that Wait While can be applied. Our third lesson learned was that a region-wide project management approach was key to rapid implementation response, and we needed to be quick. This was happening during the first wave of COVID. The customization and configuration of WaitWhile itself was only a small component of the work, and our team, led by our clinical planners, did that work within our department. We had a designated regional project manager who oversaw regional implementation, and we were also fortunate to be supported by local level project managers using all the project management tools to keep the project moving forward. And essential to the success and rapid response was the identification of a dedicated clinical lead in each program area to inform, champion, and sustain the initiative after. Current state and future state workflow mapping, we spend quite a bit of time here, laid the foundation for user testing, change management training, and creation of supporting resources. And security and privacy was a big component as well, and that required forms completion and consultations and approval. Our fourth lesson learned was that the app is simple, user-friendly, and low cost. We feel it's best for basic administrative needs, such as automating appointment reminders using texting. WaitWhile can be used at the desktop, mobile phone, and with tablets. What's neat about it is it does two-way texting, and it's super reasonable. It's about 3.6 cents per visit, and that includes 15 texts per visit. The plan is paid monthly and also covers unlimited internal users. So that's people that are assigned as administrators, staff, and unlimited number of locations. So for 10,000 visits a month, it costs us less than about $300 for the entire health authority. So just how does it work? There are two ways to register in WaitWhile. The public can self-register, or staff can register for a patient and client. And these are things that you will decide and choose when you're working through your workflows. All the fields are customizable to clinic needs, and the only mandatory fields are mobile phone and name. So you just set this up to match the needs of your clinic. And we also integrated the consent into the registration process. And we don't use WaitWhile at this time for sharing of any clinical information. So this is just to highlight a basic workflow, and this workflow is when a staff member is organizing a booking reminder to go out. So you would invite the patient, you would provide instructions and consent information, you'd enroll the patient in WaitWhile while you're on the phone. You're going to confirm right away that they received the text, because it happens instantaneously. You're going to confirm that they received the welcome message, and then you're going to configure when you want your reminders to go out. And you can also send links to resources, intake questions, and clinic information, and you can add messaging into your welcome messages, reminders. You can send some automatically and others manually. And then you finish off with clinic documentation. And your auto messages that go out, they have limited characters, so you got to get creative of how you're going to word them and have your key information. WaitWhile offers some basic analytics. We have had 25,000 visits since inception in July of 2020. We can track basics like number of locations, number of visitors, canceled, delayed, no-shows, and served. However, it's only as good as the data that's entered, and having standardized definitions of what you want to track is key to ensure robust data. We're learning that our different programs have different definitions of these different elements. We currently have 18 to 20 locations up and running, and our usage has shifted since the early days of the pandemic from using it as a waiting room management tool to 80% use for booking reminders. And I'll just do a brief highlight of some use cases. So this use case is an ambulatory CAST clinic in an acute hospital, and they created a virtual check-in and waiting room management. They improved clinic flow. They have a QR code on a poster right at the entrance to the hospital. And so when the patient arrives, they put their phone up to the QR code, and then they're given instructions on where to go next. And the reception also knows that they've arrived. There's less congestion in the waiting rooms, and there's been great positive feedback from patients, and the physicians' medical office assistants are also supporting the process. Got the next one. This is another ambulatory clinic in an acute setting, and they enabled a virtual platform for reminders, clinic information, and patient preparedness. They improved patient communication, transformed workflows, and reduced no-shows and phone calls. They transformed their workflow by going direct to the patient rather than notifying the medical practice of an appointment, and then the medical practice may or may not be notifying the patient of the appointment. So they streamlined their process, and then that also created an opportunity to change their referral form. And the last use case I'll highlight is an internal usage for VCH staff. And our Employee Safety, Health and Wellness Department uses WaitWell for two programs, the annual flu campaign and also for fit testing. It's a self-booking and reminder system, and it's accessed via our intranet. It's improved workflow efficiency, communications, and staff attendance. And just as an example, 94 staff used the app to book their flu shot in the last 2 years. All right, back to lessons learned. Our fifth lesson learned is that such a simple app has provided numerous positive impacts that have led to a better patient experience and improved staff satisfaction. And you can see on the slide there's numerous things that have been improved upon just by implementing this app. And the great thing about WaitWhile is that it does allow two-way texting, and it just can happen from the desktop. So it also gives staff an additional communication tool when needed. Just, a couple simple examples. Your dad has had a successful surgery and is now ready for pickup. That's one use. And the clinic is running an hour late, so you have more time. We'll text you when you can return. And our final lessons learned, the solution doesn't integrate with existing EMRs. Any EMR touchpoints need to be integrated into the workflows, and some clinics have multiple EMRs that may be impacted and need to be integrated. So you've got to look at documentation, data tracking, appointment scheduling, your EMRs, and what other systems you're currently using, like Paper and Outlook, and they all have to be coordinated together in the workflows. And then the last lesson I want to share is that you do still have to have a manual process for those patients and clients that don't want to participate in WaitWell. We haven't done a formal evaluation at this point, but we have received lots of positive feedback, and our usage remains strong. And what I can say is that don't take it away unless you have a replacement. And that's it.
Hi, thanks for that. It was really interesting. I'm guessing that there are some workflows where it's more challenging for staff to not get into the type of back and forth with patients where really that documentation should be going into the patient record. I'm just wondering if there's been any process flows where you've actually had to backtrack and say, like, this actually isn't a good use of WaitWhile, and instead we need to use something else. And then also the other way around, like, do you see areas where this could be a clear solution where it's not currently being used. But I guess like the main piece is that, like the example that you gave around your dad's had successful surgery, you know, you can imagine like the dialogue that could begin through that system that would not be a good use of that system.
Yeah, so it can open up a can of worms with back and forth texts. So we do put some qualifiers in there that this, in the education piece, that the line is not monitored regularly. And if for whatever reason there is a long communication that's happening, then it's best to pick up the phone and sort it out. And we do have other toolkits in our toolbox for, our tools in our toolbox for the different clinics and programs. So wait while we assess what wants to be addressed and what the needs are. And wait while is great for basic use cases, but we might use something else for something that's more complex.
So I find this really interesting, and I have CST Cerner on the brain here, so bear with me. I work at BC Cancer Vancouver, where we went live a year ago. And I'm just wondering, looking ahead to September, how you think your workflows might evolve when Cerner does go live. It obviously doesn't integrate, but I guess you're thinking about that, is that right?
We do, I don't know, can you speak to, Lionsgate launched with Cerner first, and Waitwhile was also used. I just have a former colleague in the audience that worked at Lionsgate and implemented Waitwhile there. So can you comment to that, Arlene? Yeah.
Thank you. Yeah, so at the Lionsgate CAS Clinic, they're actually live with Cerner, and so it was implemented in an area where they already had that as their source system or their EMR that they were using for scheduling. And in fact, they found the solution. It was very simple, very easy to use, and there's a lot of like preset messages that can be created. And so it kind of lifts the burden off of that administrative staff from having to do everything manually. And so they actually saw it as a value add because that clinic is extremely busy and they see a lot of patients. So it definitely helps streamline things for them.
Yeah, I'm not aware of any impacts. We haven't implemented yet at VGH and not in Richmond either. So that's why I called on Arlene for Lionsgate.
I just want to commend you for this work and say thank you. Throughout COVID, I was the head nurse educator with Julie in the emergency department. When this was implemented for the fit testing, you 100% impacted my workflow and workload, where I was able to focus more attention on the patient safety and the staff safety. So I think this is absolutely amazing, and I want to totally promote growing it more.
We appreciate you.
Glad you're using it.
I just want to double check that I heard the numbers right. So was it approximately $300 per month for about 10,000 visits? Oh, wow.
It's very, very reasonable, okay. But part of that is that you don't get a lot of vendor support. So our team does the configuration. There is vendor support through chat and phone, but we manage through our team the implementation and configurations. There is support, but yeah, it's super reasonable. It was built for retail trade. Lots of people were using it during COVID, Lululemon, and you probably used it in restaurants and whatnot.
Thank you for the presentation. I just have a quick question going back to the solution and not it being integrated with EMR, and appreciating that there is no evaluation at this point. But I'm curious to know if you've heard any feedback around comparing the clerical work pre-implementation of having to call patients to provide that appointment reminder and information compared to now having to bridge the gap between the solution and the registration platform, and getting a sense of if there's equal work or is it less, has it decreased, or in some cases, knowing this is now a new technology, did their workload actually increase because now patients may be calling them to see how to use the technology as part of their added step within their workload? Just curious to see if there was any learnings around that.
We're going to be doing a more robust evaluation on some of the projects we're doing at the moment in Richmond. So we'll have some more information in the future. It's not being pulled back. People love it and they're using it, and all those manual phone calls that you're not doing anymore. And it's also quality of care, you know, information in writing, information about preparation, that type of thing that maybe was like a verbal data dump that someone got 3 months ago when they didn't write down all the details or whatever. So those types of things have really helped. Jody, do you want to speak to our pain clinic and our colposcopy clinic in Richmond? I'm putting you on the spot, but they have really embraced it.
Yeah, just talking back to the workflow. When we even, hi everyone, sorry. When we look and do the needs assessment too, we're asking the clericals or our unit assistants how much time they're spending on the phone, doing reminders, calling, clarifying information, and it's over half an hour in a day. That's a break for them. So the other thing too that's great with WaitWhile is that for some of our elderly patients or for people who maybe English isn't their first language, you can put in a secondary contact for that caregiver or for that other support person to send that information to help figure out how to get to their appointments. So that's another thing that's helpful too.
I just wanted clarification as well. You mentioned that you can send reminders to fill out forms. Does the reminder link to the form, or does the patient still have to go then find the form and fill it out? Because it would be interesting to evaluate whether or not that led to actual better completion rates, or if it had any impact when you do your evaluation.
Yeah, so that's an area that we still need to work on better because we don't have an e-form solution where we can just link. So if the form lives online somewhere, then we can link it and then they can pull it back. It's pretty elementary and basic and WaitWhile, but you can do it.
Hi there. I was just wondering regarding the admin, like I was hearing that it reduces some load on the admin. Was there any like considerations for scope creep or like creep into the admin scope and then union considerations in terms of like reducing the need for admin?
Oh, I think they're overworked. Yeah, yeah, and huge turnover. No, we haven't. I haven't experienced any of that feedback.
Okay, thank you.
Any more questions in the room?
Is that it?
One more call. Any questions for our presenter? Okay, hearing none, why another round of applause, please. Thank you.
Thanks.
Big thank you to all of our presenters today, and a reminder, if you can take just a minute to fill out the form, it's greatly appreciated by the presenters and the organizers, and there's also a link in the app. So thank you. Next is a half-hour break, so enjoy yourself and we'll reconvene.